Good morning, everyone. I'm presenting a paper on retrobulbar amphotericin B as an adjunctive treatment in rhino-orbital mucormycosis. I have no financial disclosure. So rhino-orbital cerebral mucormycosis is a potentially life-threatening invasive fungal infection that was seen almost exclusively in immunocompromised hosts. But recently, a surge in number of cases occurred during the COVID-19 pandemic. But there is currently a lack in literature and appropriate guidelines to use the transcutaneous retrobulbar injection of amphotericin B as an adjunct treatment modality for this infection. This case report documents a case of ROCM successfully treated with TRAM-B injection in conjunction with systemic antifungals and endoscopic sinus debridement. Coming to the materials and methods, it is an interventional case report. A 35-year-old man presented with right-sided post-COVID rhino-orbital mucormycosis with right-sided cerebral palsy. He complained of right-sided facial swelling for 15 days and was associated with dulling and non-progressive on and off pain. He was a known case of diabetes mellitus in the past 1 year with a poor diabetic control and HbA1c of 10.8%. He had a history of COVID-19 infection 20 days back and with a history of hospitalization where he was given oral steroids for 5 days and oxygen therapy. His HRCT score, CORAD score on presentation was 4 and CT severity score was 1 on 25. The MRI brain with PNS, that is paranasal sinuses and orbit, and CT paranasal sinuses showed bilateral maxillary ethmoid sphenoid frontal sinusitis and was suggestive of right-sided orbital mucormycosis. On examination, his best corrected visual acuity was 660 in the right eye and 6.6 on the left eye. On anterior segment, as we can see here, the lids were edematous, conjunctiva was chemos with superficial punctate keratitis from 5 to 8 o'clock in the right eye, and the pupils had pupils were round and sluggishly reactive. The extraocular movements showed right-sided total ophthalmoplegia. He was started on IV amphotericin B in 5% dextrose twice a day for 30 days, and renal functions were monitored regularly. It was supplemented with fundus endoscopic sinus surgery, which is FES, and diagnostic nasal endoscopy with suction and clearance was done, which was followed by KOH and culture for the same. The right-sided exposure keratopathy was managed with lubricating eye drops and ointment and taping. So this is the timeline for management of this patient and intervention. So day 0, FES was done for the right side and IV amphotericin B was started. Day 4, diagnostic nasal endoscopy was done and suction and clearance was again done, and he was referred to ophthalmology OPD where his visual acuity was recorded in the right eye as 660. By day 10, his visual acuity reduced to counting fingers 2 meters. So on day 11, 12, 13, in accordance with the article published by Hiyabayashi, we had given 0.7 ml, 3.5 mg injection TRAM-B in the right eye. And the visual acuity was recorded as CF 2 meters on that day with right eye total ophthalmoplegia. One injection was given on 11th day, 12th day and 13th day. On 20th day, we noted slightly gain in the extraocular movements, and that's when we decided to repeat the site of injections again for 3 days, the same dose. By day 22, his visual acuity had gained to right eye, 660. This was in conjunction with the IV amphotericin B that was already going on. By day 47, he had restored there were partial restriction of movements, and his best corrected visual acuity was 618. As we can see in the images, on day of presentation, his right eye had total ophthalmoplegia, and on day of discharge, we can see the vertical dictions are present. So on discharge, visual acuity improved to 618 with partial restoration of the movements, extraocular movements. We discharged this patient on tablet posaconazole 300 mg twice a day for 2 days, followed by OD dosage for 21 days, lubricating eye drops and eye ointment for the right eye, and right eye lid taping at night. Conclusion and discussion. The drawback of the systemic antifungals is their limited tissue penetration, which can be overcome by the local administration of antifungals, thus reducing the burden of orbital disease. Studies with larger sample size are needed to ascertain the role of TRAM-B in halting and progression of fungal orbital infection. These are my references. Thank you.
Can you show the MRI plates? Is it here?
Ma'am, no, I don't have it in the presentation. Ma'am, we have given in the at the junction of lateral 2/3 and medial 1/3. Lateral 1/3 and medial 2/3, and we use the 18 gauge needle, ma'am. We advanced it till the hub of the needle was reached in the skin, and then after a negative aspiration for the blood, we injected the injection. We had reconstituted amphotericin B liposomal. Sorry, ma'am. Ma'am, I don't remember. Sorry.
And what was the schedule? For how many days you gave it?
Ma'am, 3 days we gave 3.5 milligram, and we reconstituted with 10 ml, 50 mg vial comes, ma'am. We reconstituted with 10 ml sterile water. After that, we draw 0.7 ml, so concentration comes to be 3.5 milligrams.
Then after 3 days?
Ma'am, only 3 days we give, 3 consecutive days, and then we observe, because the action of amphotericin B can range from 24 hours to 15 days, so we followed that.
Okay, did you encounter any toxic effects of the drug?
No, sir, not in this patient, not on the local administration.
Okay, thank you.